Level up your skills with the RSNA Imaging AI Certificate Program, where case based courses equip you for the future. Master the fundamentals, dive deeper with advanced topics, or obtain a diagnostic edge to meet those high demand moments. Gain confidence, efficiency, and career advancement in this rapidly evolving field. Not sure where to begin? Take the quiz at rsna.org/AI certificate.
Hi, everyone. Welcome to the RSNA Radiographics podcast. So, today we're diving into the fascinating and complex world of Erdheim-Chester Disease, which we'll call ECD for short, which is a rare multi-histiocytic neoplasm. Joining us are Doctors Yashant Aswani and Dr. Shehbaz Ansari, the authors of the article Imaging in Erdheim-Chester Disease, published in the September 2024 issue of Radiographics. Doctors Aswani and Ansari, thank you for being here with me.
Thank you for having us. It's a pleasure to discuss this important topic. I'm Dr. Yashant Aswani. I'm an abdominal radiologist at the University of Iowa Healthcare in Iowa City.
Hi, I'm Dr. Shehbaz Ansari. I'm a neuroradiologist at the Rush University Medical Center in Chicago.
Well, thank you both so much. Well, let's just get started. What is Erdheim-Chester disease?
Named after its discoverers, Erdheim-Chester disease is a rare, multi-organ histiocytic disorder that typically affects elderly white men. Interestingly, it was not until 2016 when Erdheim-Chester disease was recognized as a histiocytic neoplasm similar to its cousin Langerhans cell histiocytosis.
So you mentioned that Erdheim-Chester disease is the histiocytic neoplasm. What exactly is that?
Erdheim-Chester disease, henceforth referred throughout the podcast as ECD, is a neoplasm of a specific type of white blood cell called histiocyte. Once mutated, the histiocytes can grow in various tissues and organs to cause disease manifestations. These mutations have been described in MAP kinase and PI3K pathways. Notable is the mention of a protein BRAF in the MAP kinase pathway, which is the most common mutation in ECD.
Why should we know about ECD?
ECD is a rare but often underdiagnosed multisystem histiocytic neoplasm. We need to be better aware of this entity to offer timely treatment to improve patient outcomes. Without treatment, ECD is almost always fatal. Radiologists play a key role in the management as ECD can closely mimic several other pathologies outlined in the article, some of which we would discuss during this podcast. In addition to conventional treatments, now ECD has US FDA approved targeted therapies due to better understanding of the molecular pathogenesis.
So when should we suspect a histiocytic neoplasm?
Suspecting a histiocytic neoplasm, including ECD, Langerhans cell histiocytosis, and Rosai-Dorfman disease, is challenging since they are rare and may have diverse and non-specific clinical features. However, any combination of the following features should raise a suspicion of histiocytic neoplasm. These include metadiaphyseal osteosclerosis around the knee, idiopathic central diabetes insipidus, positivity for molecular markers like CD63 or CD168 at tissue biopsy, hairy kidneys, coated aorta, upper lobe predominant nodulocystic lung lesions in smokers, and punched out lytic lesions of flat bones.
Okay, so after we suspect a histiocytic neoplasm, how do we actually confirm the diagnosis of ECD?
Once we suspect a histiocytic neoplasm, the next step is imaging and finding targets for biopsy. Unlike most tumors, biopsy may not always give a final answer. Hence, confirmation of diagnosis is dependent on integration of clinical features along with imaging that we will subsequently discuss and pathological findings.
as a radiologist, what can we do? What role can we play in the management of ECD?
Radiologists play a crucial role at every stage of ECD management, from determining the location and extent of the disease to identifying biopsy targets. Radiology guides both diagnosis and treatment planning. Additionally, imaging helps in predicting prognosis and assessing treatment response, making it an integral part of patient care.
So that's pretty interesting. How does radiology help in determining the prognosis of the disease?
Well, involvement of critical regions such as central nervous system, lungs, or retroperitoneum on imaging are amongst the factors associated with poor prognosis, apart from clinical parameters such as elevated C-reactive protein.
Okay, well, what about the role of radiology in guiding treatment?
Imaging helps differentiate patients who require systemic therapy from those few who can be observed. Patients with asymptomatic or minimally symptomatic disease involving non vital organs such as bone can be observed, while all other patients need systemic treatment. Notable mention is of US FDA approved vemurafenib for BRAF mutation and cobimetinib for MEK mutation.
What imaging modalities are recommended for evaluating patients with ECD?
Baseline vertex to toe FDG PET CT, MRI brain, and cardiac MRI are recommended in all ECD patients for staging evaluation. Additionally, depending on the organ of involvement, specific radiologic investigations can be ordered. For example, CT sinuses with contrast, CT chest, abdomen, and pelvis with contrast, particularly when FDG PET CT cannot be performed, MRI pituitary, MRI orbit with contrast, HRCT chest, bone scan, renal artery Doppler, etc. For assessing treatment response, functional imaging does a better job than anatomical imaging. As healing occurs with fibrosis, the lesion size and appearance on CT or MRI may not correlate with disease activity.
So, when we're reading these examinations, what are some of the common organ systems that are involved in ECD that we should be looking especially hard at?
By far, skeletal system is the most frequently involved site. Other common sites of involvement include kidney and retroperitoneum, cardiovascular system, lungs, and central nervous system.
Can you describe the skeletal manifestations?
Absolutely. Skeletal involvement is present in nearly all ECD patients. But despite the extensive bone infiltration, there is no increased risk of fractures. In more than half of the cases, bone lesions occur concomitant with extraskeletal involvement, reinforcing the systemic nature of the disease. The appendicular skeleton is more commonly affected than the axial skeleton, with a strong predilection for the long bones of the lower limbs. A typical ECD bone lesion is osteosclerotic, most often seen in the diaphysis and metaphysis of femur, tibia, and fibula, particularly around the knees, and is virtually pathognomonic. Radiographs and CT reveal bilateral symmetrical cortical sclerosis, which in time progresses to involve the cancellous bone and may obliterate the bone marrow cavity. On PET-CT, these sclerotic sites demonstrate increased radiotracer activity, again, a nearly pathognomonic finding. Unlike CT and PET-CT, which provide highly specific features, MRI findings in ECD bone lesions are nonspecific, and histiocytic infiltration of bone marrow appears as hypointense on T1-weighted sequences and heterogeneously hyperintense on T2-weighted and STIR sequences.
Bone lesions in ECD are osteoblastic, unlike the punched out lytic lesions of Langerhans cell histiocytosis. Is that correct?
Yes, that is correct.
How can ECD be differentiated from other osteosclerotic bone diseases?
Wow, that's a great question. Yes, ECD needs to be distinguished from various osteosclerotic bone lesions, including bone infarction, enchondroma, renal osteodystrophy, osteoblastic metastases, chronic focal osteomyelitis, myelofibrosis, and Paget's disease. Beginning with bone infarction, both ECD and bone infarction commonly affect the femoral and tibial metadiaphysis and may be bilateral. However, unlike ECD, bone infarction is limited to the medullary cavity, has a serpiginous sclerotic border, and shows preserved bone marrow signal on MRI. Additionally, bone infarction does not show increased uptake on bone scintigraphy, unlike ECD. Enchondroma of a long bone with a calcified matrix can mimic ECD. However, enchondroma is going to be unilateral, so endosteal scalloping, and a T2 bright chondroid matrix, which may show rings and arcs calcification. Next differential diagnosis is Paget's disease. Both Paget's disease and ECD are more common in elderly men, but unlike ECD, Paget's disease often affects both the axial and appendicular skeleton asymmetrically and frequently causes bone expansion and deformity. Finally, conditions like renal osteodystrophy, osteoblastic metastasis, chronic focal osteomyelitis, and myelofibrosis can be distinguished based on clinical history, laboratory findings, and biopsy results.
Wow, that is very comprehensive. So let's now talk about the second most common sign of involvement, which is the retroperitoneum and renal disease.
Retroperitoneal and renal involvement occurs in up to two-thirds of ECD patients and typically presents as bilateral infiltrative soft tissue masses in the perirenal and posterior pararenal spaces, a pattern commonly referred to as the hairy kidney sign. On CT imaging, this soft tissue appears isodense to skeletal muscle and demonstrates mild post-contrast enhancement. On MRI, it is iso to hypointense relative to skeletal muscle both on T1 and T2 weighted sequences and similarly shows mild post-contrast enhancement. One of the limitations of FDG PET CT in detecting retroperitoneal ECD is that normal renal parenchyma exhibits intense physiological FDG uptake, which can obscure subtle perinephric disease. As a result, contrast enhanced CT is often preferred for evaluating perinephric involvement.
What complications can arise from perinephric ECD involvement?
Perirenal soft tissue infiltration in ECD can lead to progressive renal atrophy due to chronic compression. In some cases, the infiltrative tissue extends towards the renal sinus, potentially leading to hydronephrosis by obstructing the renal collecting system. Additionally, ECD may encase the adrenal glands, although this rarely results in adrenal insufficiency.
What are the differential diagnoses for perirenal soft tissue infiltration in ECD?
The perinephric rind of soft tissue seen in ECD is nonspecific and has many differential diagnoses, including lymphoma, retroperitoneal fibrosis, Rosai-Dorfman disease, amyloid, and extramedullary hematopoiesis. Both ECD and lymphoma may present with perinephric soft tissue as well as circumferential periaortic soft tissue that shows uptake at FDG PET CT. However, contiguous involvement of kidneys or perinephric space from retroperitoneal masses and presence of lymph nodes is a common pattern of renal lymphoma. On the contrary, ECD rarely affects the lymph nodes. Next differential is retroperitoneal fibrosis. Both ECD and retroperitoneal fibrosis cause hydronephrosis. Soft tissue infiltrates in ECD are present around the renal hyla and proximal ureters, whereas the soft tissue in retroperitoneal fibrosis is epicentered around aortic bifurcation and hence affects the distal ureters. As retroperitoneal fibrosis extends more superiorly, It lies anterior and lateral to the aorta and not circumferential like ECD, and this soft tissue rarely infiltrates the renal hyla and perinephric spaces. Immunoglobulin G4 related retroperitoneal fibrosis may also show pancreatic involvement. Perinephric soft tissue in the presence of plasma cell dyscrasias or chronic inflammatory or infectious processes favors the diagnosis of amyloidosis. Unlike ECD, perinephric amyloid deposits frequently show calcification. Yet another differential diagnosis for perinephric soft tissue is extramedullary hematopoiesis. Both ECD and extramedullary hematopoiesis show uptake at FDG PET CT, but due to the presence of bone marrow elements, extramedullary hematopoiesis also shows uptake of sulfur colloid. A history of hematologic disorders and characteristic additional sites of involvement, such as the liver, spleen, lymph nodes, and paravertebral regions, favor extramedullary hematopoiesis. Finally, another cousin of Erdheim-Chester disease, Rosai-Dorfman disease, may also show perinephric soft tissue. But the most common pattern of renal involvement in Rosai-Dorfman disease is bilateral perihilar masses. In contrast to ECD, Rosai-Dorfman disease is more common in children and young adults and shows lymphadenopathy, especially in the cervical region.
Wow, that is a lot of differentials. So moving up to the chest, what chest findings should a thoracic radiologist be aware of in ECD?
Thoracic manifestations of ECD can be categorized into cardiovascular and pleuropulmonary findings. ECD can infiltrate all three layers of cardiac, with the infiltration of myocardium of the right atrium and atrioventricular sulcus forming a pseudotumor, the most common cardiac presentation. In terms of vascular involvement, soft tissue of ECD can coat various blood vessels, most commonly the aorta. When it affects medium-sized vessels such as coronary, renal, and mesenteric arteries, it can lead to downstream ischemia, causing myocardial infarction, renal ischemia, or mesenteric ischemia. Ischemia may persist despite treatment due to residual perivascular fibrosis. Pulmonary involvement in ECD is often asymptomatic, and in many cases, chest radiographs appear completely normal. However, chest CT can reveal smooth perilymphatic interstitial thickening, which affects the interlobular septa, peribronchovascular regions, and visceral pleura. Over time, this can progress to pulmonary fibrosis. Unlike Langerhans histiocytosis, ECD is not linked to smoking and does not cause cystic changes.
Now we've talked about the abdomen, the chest, and the bones. How common is central nervous system involvement, and how does this typically manifest?
CNS involvement occurs in a quarter to one half of the patients, but it is rarely an isolated finding. You will see involvement of sinonasal cavities or the orbits in all patients with CNS disease. Hypothalamus and pituitary are the most frequently affected sites in the CNS. In fact, a lot of these patients present with central diabetes insipidus and later end up getting diagnosed with ECD. And enlarged pituitary stalk is what we are looking for here. The brain parenchymal involvement is predominantly infratentorial and can either look like a tumor in the form of nodular, markedly enhancing mass, or mimic degenerative brain atrophy with T2 and flare hyperintensity in and around the dentate nuclei, lacking enhancement and mass effect. Then we can have extraaxial ECD in the form of diffuse pachymeningeal thickening or a meningioma-like well-defined dural lesion. But unlike meningioma, ECD lesions are hypointense on T2 weighted imaging. The combination of meningeal, orbital, and sinonasal disease is also seen with Langerhans histiocytosis and granulomatosis with polyangiitis. But the bone involvement in them is lytic, while ECD is known for its sclerotic bone lesions.
Well, since ECD is a multisystem disease, what other structures can be involved?
As mentioned just now, we can have orbital involvement where we see bilateral intraconal, specifically retroocular disease, either in the form of masses encasing the optic nerve sheath or diffuse infiltration of retroocular fat. Then we can have sinus disease causing non-specific mucosal thickening and bony sclerosis, which shows radiotracer uptake. Skin involvement is typically in the form of periocular yellow to brown red papules, plaques, or nodules, specifically in the inner canthus. Testes can also be involved, especially in cases of histological overlap of ECD and Rosai-Dorfman disease, known as mixed histiocytosis. It presents as ill-defined nodules on ultrasound. Rarely, biliary system, pancreas, breast, bowel, or lymph nodes can also be involved.
So, wow, ECD really is a multi-system disease. Lastly, what message would you like to give to our radiologists who may encounter a patient with ECD?
Consider further evaluation for ECD in patients with osteosclerosis around the knees, hairy kidneys, coated aorta, and right atrial pseudotumor. A multidisciplinary approach with pathology and genetics is crucial for diagnosis and management.
Well, thank you both so much for speaking to me today. I feel like I learned so much. And for our listeners, I hope you go and read this article and look at all the images. Thank you, Doctors Aswani and Ansari, for joining me today.
Thank you for having us.
Thank you.